Pediatric Hematology. So the objective of this live learning session is describe characteristics and physical assessments and laboratory findings for common pediatric hematologic conditions, and we want to identify appropriate management for common pediatric hematologic conditions. So, there we go. So types of blood cells. So in the hematologic system, there are types of blood cells. We have red blood cells, white blood cells, and platelets. The functions of the hematologic system: blood clotting, which are the platelets, immunity, which are the white blood cells, and then heat regulation and transport of oxygen, which are the red blood cells. So that's what we're going to be talking about today, red blood cells. So a mature red blood cell is a donut shape, and it has kind of the concave center. This is related to the loss of the nucleus. A mature red blood cell's lifespan is 120 days. So remember that when we start talking about some hematologic conditions, a normal mature red blood cell lifespan is 120 days. So your red blood cells, you have reticulocytes. So reticulocytes are immature red blood cells, and these are often seen in response to anemia. And so you have your normal values there. So there's problems. There can be problems with red blood cells. So you can have a problem with cell production, and then this is going to be your acquired or idiopathic aplastic anemias. Then you can have a problem with cell maturation of the red blood cells, and this is seen in nutritional imbalances like iron deficiency anemia. And then you have cell destruction of the red blood cells. And this is going to be seen in your hemolytic anemias such as sickle cell disease. So let's just talk about anemia. Anemia is a reduction in the total number of circulating blood, blood cells. So it's a decrease in the quality or the quantity of hemoglobin. So basically, this is a condition which the number of red blood cells or the hemoglobin concentration is reduced below the normal value for a child's age. And based on the child's age, that's going to be the lab values. It's going to be a value, a norm based on the patient's age. So you can see here we have less than 11 or less than 9 is super dangerous. But anytime you have a decrease in the amount of circulating red blood cells, you are anemic, and this causes decreased oxygenation to all of your tissues. So what is anemia caused by? So it can be caused by impaired red blood cells. It can be caused by a decrease in the red cell production, and this is your iron deficiency anemias. It can be caused by blood loss. Of course, anytime you have blood loss, you're going to be anemic. It can be caused by erythrocyte destruction, and this is going to be your sickle cell disease. And then it can be a combination of the three. So those are the causes of anemia. So today we're going to be talking about two types of anemia. We're going to be talking about iron deficiency anemia and sickle cell anemia. So iron deficiency anemia. It is the most common anemia in the United States. Prevalence is 25% of children ages 10 to 15 months of age. So basically, iron deficiency anemia is your body needs iron in order to make hemoglobin. When your body is iron deficient, it results in a decrease in your hemoglobin level. So you're anemic because your body can't make the hemoglobin because it lacks iron. So this is greater in African American children, and the most common cause is the poor dietary intake of those iron-rich foods. There's other risk factors for iron deficiency anemia also. Premature birth, so anytime you have preemies, they're at risk for iron deficiency anemia. Toddlers with excessive intake of cow's milk. So if you have your toddler that comes in there and you take a CBC, you take a CBC, and the child is anemic, ask that mom, what does this child drink? These are more often going to be the children when he drinks a lot of milk. He always has his cup of milk. So an excessive intake of cow's milk puts the child at risk for an iron deficiency anemia. Malabsorption disorders, prolonged diarrhea, poor dietary intake of iron, of course, and blood loss. All of these are risk factors for iron deficiency anemia. So how is iron deficiency anemia diagnosed? This is going to be through the history and the physical. So you're going to have a patient coming in. When you're gathering your history and you're taking your physical, you will see some of these characteristics. These are going to be your pertinent positives. You're going to have the difficulty breathing, fatigue with exertion, headache, poor concentration, heart palpitations, irritability, pallor, tachycardia, murmur, anorexia, or pica. And in severe cases, on the physical exam, you'll see something called glossitis or chelosis, or you'll see brittle concave nails. And I'll show you a picture of that later on. And pica, for you guys who don't know, so pica is just an eating disorder manifested by craving or ingesting any material not normally considered as food. So this could be your starch, your ashes, crayons, dirt, clay, grass, chewing on plastic or wood, just different things. You'll hear all sorts of things. I had a patient that loved to chew on paper and tissue paper, toilet paper. She would chew on toilet paper. So if mom or if family is saying that, she loves to eat a lot of ice, she loves to eat, she just eats dirt, then you want to do a CBC and look at her hemoglobin and assess for anemia. So when you gather your history, these are some of the questions you want to ask. These are the key questions. Onset and duration of symptoms. How long have you had these symptoms? Related to feeding practices. Yes, we want to talk about what are they eating? Do they eat a lot of vegetables? Do they eat those iron-rich foods? Or do they not like them? Does family never really provide those types of foods? Are they experiencing pica? Are they eating non-food things? Um, in adolescence, you want to question the blood flow during menses. You want to ask how many pads or how many tampons are they using a day? And then medication history. Are they taking any sort of medication that could decrease the hemoglobin or the hematocrit? And those key medications are NSAIDs and aspirin. Physical exam. So on the physical exam, uh, growth patterns, they may be a little smaller. You want to assess those and make sure that they are falling in within normal limits of the growth chart. Vital signs, like I say, you want to assess the vital signs to make sure what is their heart rate, what's their blood pressure. You want to observe for signs of pallor, and here is a picture of a patient with pallor. And your darker skinned children, of course, it's not going to look like this. It's going to be just a lighter color of their actual skin color. You want to examine the tongue and the corners of the mouth for the chelosis and glossitis. Heart auscultation. Do you hear a murmur? Do you hear a murmur? In the abdominal exam, you want to evaluate for an enlarged spleen. And so here's the chelosis and glossitis that you may see with children who have anemia. Labs. So in a child who is anemic from iron deficiency anemia, these are the tests that you'll normally see. You'll see a low hemoglobin and hematocrit, of course. That's the biggest one you'll notice. You'll see a low MCV, a low ferritin. Of course, you'll see low serum iron. So you'll have a low iron level. Um, and then on the blood smear, if you're able to look at the blood smear in your clinic, they may show oval-shaped cells with pale centers. So those centers of the nuclei, where the nuclei is supposed to be, you'll see a very pale center. Management. So management is with iron supplementation. You want to give them iron. They want to take the iron on an empty stomach, preferably with something acidic like orange juice. It just helps absorption better. Now, this does stain teeth. It does stain teeth, so you want to make sure that you can use a straw if they're old enough to use a straw, or that they are rinsing their mouth out after they take the iron supplementation. And then continued management is going to be educating the family on increasing iron containing foods. So, this is going to be for your infants who are diagnosed with iron deficiency anemia, who are at risk for iron deficiency anemia. You want to make sure that they're using iron fortified cereals and iron fortified formulas. For your older children, their diet needs to consist of some dried beans, lentils, peanut butter, those green leafy vegetables, and iron fortified breads um, and cereals, and then iron, and then red meat, of course. Red meat is going to contain your iron. So, after doing the iron supplementation and then changing in diet, you want to bring them back in for a month for another physical exam and a repeat CBC. The CBC should show an increase in the hemoglobin um, by at least zero point 0.1 milligrams, okay, per deciliter. We should see a slight increase in a month. If you don't, you need to, see are they being compliant? See have they changed their diet? Are they taking the iron supplementation? So check compliance, and then you might have to start evaluating for other causes of anemia. But if we do see an increase, you want to continue iron therapy for 2 to 4 months after the anemia has been reversed. So that's the management of that. Oh, I do want to mention that WIC. You also want to refer to WIC. If you do um, diagnose a patient with iron deficiency anemia, WIC has great resources and help in allowing them to get those foods, educating them on those foods, and helping them shop and prepare those foods. So you want to refer them for WIC for counseling and for resources. Sickle cell anemia. So that's the next type of anemia that we're going to discuss. So sickle cell anemia is an autosomal recessive disorder, and it affects African Americans, Mediterraneans, Middle Eastern, and the Indian population. It is one of the most prevalent genetic disorders, and it's diagnosed on the newborn screening. So, 1 in 4 African American persons have sickle cell disease, and this is 8% of the general population is going to have just sickle cell trait. So, like I said, this is most common in African Americans, but you also see it in Mediterraneans, Middle Easterns, and the Indian population. So, depending where you practice, you may or may not have these populations in your area of where you practice. However, you still need to be familiar with sickle cell disease um, because um, with um, this sickle cell disease is migrating in other populations due to interracial couples having children. So, you might encounter it in a patient that you wouldn't think had it. And it's just because of interracial couples having children. Like I said, it's diagnosed on the newborn screening. So make sure that when those newborns come in there for their newborn follow-up, that you are looking at that newborn screening panel and you are assessing for sickle cell anemia. So before we dive into sickle cell disease, I do want to discuss the hemoglobin. I want to make sure that you understand that there's different types of hemoglobin. So in your blood, there's different types of hemoglobin in your blood. Normal types of hemoglobin right here are hemoglobin A and F. A is the most common type of hemoglobin. It's found in healthy adults and children. Okay, but then you have hemoglobin F. Hemoglobin F is fetal hemoglobin. So this is the type of hemoglobin that is found in unborn babies and is found in newborn babies. Um, and as the baby gets older, the hemoglobin F is going to be replaced with hemoglobin A, or it's going to be replaced with hemoglobin S. The abnormal types of hemoglobin. So abnormal types of hemoglobin are hemoglobin S, and this is the type of hemoglobin that's found in sickle cell disease. And then you have hemoglobin C, and this is another type of hemoglobin. Some children with sickle cell disease has hemoglobin C, but it does not carry oxygen well. So it doesn't work as well. It's not sickled, but it doesn't work as well. It's not as good as that A or F hemoglobin. There's other types of hemoglobin as well, but these are kind of the main four that you kind of really need to know about. So in order for a child to have sickle cell disease, they have to have hemoglobin S. And here is a example of a hemoglobin profile, and it breaks down just the amount of each hemoglobin that a patient has in their blood. So sickle cell anemia. Here you can see what a normal red blood cell looks like, and we talked about it. It's disc shape. It has the concave or the flat centers from losing the nucleus. And then here you have a sickle cell. So a sickle cell, they're rigid and they're sticky, and they cause the clumping and clogging in the small vessels in the veins. And this leads to decreased oxygenation of the tissues and organs. So that's a sickle cell. So, like we discussed, sickle cell anemia is diagnosed on the newborn screening results. And there's different types of sickle cell disease. So there's a lot of types. So we're just going to talk about the four main types of sickle cell disease. So you have hemoglobin SS, and you have hemoglobin S beta 0 thalassemia, you have S beta plus thalassemia, and then you have SC disease. So based on what type of hemoglobin you have in your body and hemoglobin, how much of that hemoglobin you have in your body, that determines your sickle cell diagnosis. That determines what type of sickle cell disease you have. And as the FNP taking care of these patients, this is already done for you. If you see a child who has sickle cell disease on their newborn screening, you refer them to hematology. They go to hematology. Hematology will run all of these tests. They will look at the smears. They will look at the hemoglobin profile, and they will diagnose the patient with a specific type of sickle cell disease. And all of that information will be sent back to you. And so you will know what you need to look out for and what you need to do to help the hematologist manage your patient. So here we just have a severity scale. On the severity scale is based on the number of sickle cells in the body. Basically, the more sickle cells or the more sickle hemoglobin you have in your body, the more severe your disease. So here is a homogo- homozygous hemoglobin S. This is hemoglobin SS. Right here on the severity scale, this is the very severe, the most severe form of sickle cell disease. So they have way more sickle cells and less normal or less fetal hemoglobin than the other ones. So this one is the one we're going to talk about here. So it's true sickle cell disease, homozygous SS, hemoglobin SS. So hemoglobin SS disease is true sickle cell anemia, the most severe form of disease. Like I said, they have more sickle hemoglobin. They have more S hemoglobin in their bodies. So clinical manifestations vary from patient to patient. Now, this is the more severe form of sickle cell disease, but it doesn't mean that the patient is just sick all the time and always in the hospital. Sickle cell disease is it's very patient specific. Some patients can have hemoglobin SS and they're fine. We watch them, we monitor them, but they don't have a lot of complications. And then other SSDs, yeah, they may be in the hospital all the time. They may have a lot of pain crises, um, but it's very patient specific. The thing is, if they have hemoglobin SS disease, there are certain things that they are at risk for that we as healthcare professionals and as F&Ps, we have to monitor them for. Okay. So someone that's diagnosed with SS, they're going to be anemic, right? They're going to have a low hematocrit, 18 to 20. And so just going back to kind of those first slides, they are anemic um, because they have red cell destruction, right? So talking about a normal red blood cell, the lifespan is 120 days. A patient with sickle cell disease, those sickle cells only have a lifespan of 10 to 20 days. So their body makes the red blood cells, the red blood sickle, and then the red blood cells um, die or they deconstruct or they're destroyed in 10 to 20 days. So that's why they're anemic. So anytime you have anemia or a loss of red blood cells, guess what you have? Elevated reticulocyte count. So you're going to have an elevated retic count because that body's saying, hey, I need more red blood cells. Go ahead and throw out those reticulocytes. They're not mature yet, but we need them. We need them. So you're going to have an elevated reticulocyte count. And on the blood smear, you're going to see sickle cells, which is here, and target cells, and you may have pain crises, and that's what episodes of vaso-occlusion. You have paler, jaundice, and splenomegaly. So where does blood flow? Blood flows all throughout the body. So when you have a patient with sickle cell disease, their issue is their blood flow. So anywhere blood flow is affected can be affected by sickle cell disease. So here are a list of common complications of sickle cell disease. There are more, but we're just going to kind of discuss these today. So pain is the most common. When people hear sickle cell disease, they think of pain. Oh, they just kind of hurt all the time. Um, so yes, pain is the most common, followed by infection. Infection is another common complication, and infection actually is related to more deaths and hospitalizations of children with sickle cell disease. So pain is what you think of. Infection is what takes them out. It's the more serious complication of sickle cell disease. But I want you to also know that when you talk about that fetal hemoglobin, a baby is born and they have fetal hemoglobin. Well, as they get older, later on in infancy, that fetal hemoglobin will turn into, like I said, more A hemoglobin, which is the normal hemoglobin, or it'll turn into S hemoglobin, the sickle hemoglobin. So therefore, you won't have a patient with sickle cell disease experiencing these complications until later on in life, later on in infancy, and then as they get older, that's when they're going to have these complications. They don't have complications early in infancy because they have that protective fetal hemoglobin helping them out. So pain, dactylitis is just another form of a pain crisis, and it happens in the infants later on in infancy. Infection we discussed, anemia, stroke, acute chest syndrome, that's that ACS, pneumonia, splenic sequestration, gallstones, and priapism is in males. So these are some common complications, and we'll review them. So vaso-occlusive pain. So vaso-occlusive crisis, you might hear say, or it's a pain episode. It's a sickle cell crisis. That's what it is. That's what it is. And it results when sickle cells occlude blood flow in those small veins and vessels. And anytime you have lack of blood flow to tissues or organs, you have destruction, but you have pain with that destruction, right? So these are the pain episodes. And it occurs in response to certain conditions. Infection. So infection causes those sickle cells and causes cells to sickle. A decrease in oxygenation causes red blood cells to sickle. Dehydration causes red blood cells to sickle. And so does fever, stress, and extreme temperatures. So, anytime you have a patient with sickle cell disease, if they're exposed to any type of infection, any type decrease in oxygenation, which means maybe they're running around and playing, maybe they're out on a hot summer day playing basketball at the park and they don't stop for a rest and they don't stop for a water break. You have decreased oxygenation, you have dehydration, you have extremes of temperatures. All of these are going to cause that patient's red blood cells to sickle. They're going to go into a sickle cell crisis. Same thing with fever and stress. They're going to go into a sickle cell crisis. So we have to prevent these things from happening in these patients to prevent vaso-occlusive pain crises. So, as I mentioned earlier, children may not experience pain um, early on in infancy. They may start experiencing pain as early as 6 to 9 months. So 6 to 9 months, that's when that fetal hemoglobin, that hemoglobin F, it starts going to either hemoglobin A or hemoglobin S. More than likely in a child with sickle cell disease, it's going to go to hemoglobin S. So this is the patient at this age. If a patient is hurting, it could be sickle cell related. And like I said, pain is the most frequent reason for ER visits and hospitalizations. Pain is what you think of when you think of sickle cell disease. But just know that it's not going to be sickle cell pain until 6 to 9 months because before that, they're protected with F hemoglobin. Treatment. So we want to evaluate the cause of the pain, okay? Because not all pain is sickle cell pain. So when they come in and a patient has sickle cell disease and they say that their leg's hurting, well, let's not automatically go to, oh, it's a sickle cell crisis in the leg. Let's think of other things it could be. Was the child out running around and fell and hit his leg? Um, you know, was the child wrestling and he bumped his knee? So let's try to rule out other things of of pain that could be causing the pain. If they come in with abdominal pain, well, has the child had a bowel movement in the last few days? Could it be constipation that he's complaining of pain in his abdomen? Is it sickle cell disease or is it constipation? So let's rule out other causes of pain. But then when you rule those out, if it is considered true sickle cell pain, then we have to act accordingly. We have to treat accordingly. So we want to maintain adequate hydration. So push fluids. If they're super dehydrated, if they're really in pain, maybe even starting IVs and doing um, um, fluid resuscitation, adequate pain control. Is it something we can manage with Tylenol and ibuprofen, or is the child requiring more stronger pain medication? Do we have to give narcotics for pain control? And then hydroxyurea. Hydroxyurea we'll talk about a little bit later, but it is used not to treat pain, but more to prevent pain episodes from happening. Dactylitis. So dactylitis, that was on that list of complications. This could be the very first pain episode. And what it is, it occurs between 6 months and between 6 months and 3 years of age. And what it is swelling in the hands or feet. We could be with or without tenderness, and the site can be red and the site can be warm. So this is a pain episode. You think about those sickle cells occluding those small vessels and veins. It happens in the hands. So sickle cells clog them up, and then you just have decrease in blood flow, but blood is still going there, so it swells. Um, so here's a picture of dactylitis, just swelling in the hands or foot. And more than likely, it is going to be tender. And sometimes it's hard to tell because these little, 6 month, 7 month olds, they're chubby anyway. Um, but it's more than just chubbiness. It's a little tightness to it. It may be red, it may be warm. They don't want to move. They're acting sick. They're crying and clingy. They don't want to hold anything with their little hands. They don't want you to touch their little hands. They may or may not have a fever with this. So you're going to be able to tell dactylitis. And like I said, there's swelling in the hands, but there's also swelling in the feet as well. Treating it's just like treating a vaso-occlusive crisis. It's just like treating a pain episode. So you want to increase fluids, warm baths, and compresses. When you think about anytime you hurt something because of blood flow, anytime anything is hurting because of lack of blood flow, anything warm is going to help increase that blood flow. So you want to do warm baths or compresses, Tylenol with ibuprofen. You can prescribe narcotics. Um, and like I said, if they have a fever with this, um, you definitely want to investigate further of what's causing the fever, what's going on with them. So, a question: at what is the earliest age is it possible for a child to experience their first pain crises? The answer is B, 6 to 9 months. So it's important to know that if a child comes in there and they're younger than 6 months, you want to investigate other things of causing the pain or irritability or, just not acting right. Evaluate for other things other than sickle cell. I mean, it still needs to be on your differential list, but you want to evaluate um, other things as the cause of pain. After 6 to 9 months, uh, sickle cell needs to be high on your list of differentials. Infection. So, infection is another big common complication of sickle cell disease. It's the most common cause of death in pediatric sickle cell patients. And this is due to the impaired function of the spleen. So, it's due to the impaired function of the spleen, and the greatest risk is due to pneumococcal infection. So pneumococcal sepsis is a child with sickle cell disease greatest risk for infection. So let's just quickly talk about the spleen. So the spleen acts as the filter to the body, right? But a child with sickle cell disease, their spleen doesn't work correctly. Unknown cause. Not really sure why it doesn't work correctly, but we do know that those sickle cells get clogged up in that spleen, right? And for some reason, with the spleen not working correctly and sickle cells getting clogged up in the spleen, the function is off and it allows encapsulated organisms or bacterias, particularly the pneumococcal bacteria, to get into the body. It doesn't filter it out like it's supposed to. So it gets into the body, and anytime you have bacteria into the body, you could have a chance for sepsis. So, what do we do? We know a child with sickle cell disease is at risk for this. So, what do? We have to prevent infection. So we give them prophylactic penicillin. So any child that has sickle cell disease, they come into your clinic, you see sickle cell disease on that newborn screening, or you see that they were diagnosed with sickle cell disease, we have to make sure that they are on prophylactic penicillin. So birth to 3 years of age, you want to do 125 milligrams of penicillin VK twice a day. After 3 years of age, when they turn three, from 3 to 6 years, we want to increase that dose to 250 milligrams BID. If they have a penicillin allergy, we can do something like erythromycin. We also want to make sure when you talk about immunizations, we want them to have all of the normal pediatric immunizations recommended by the CDC. However, there are two vaccines that these children will get that your children without, um, increased risk for sepsis will be getting. They will be getting the Pneumovax. So we want the Pneumovax 13 and the Pneumovax 23. So we want to make sure that they get these. So follow the CDC guidelines for how and when to administer these vaccinations. But you do want to make sure that any child with sickle cell disease is taking prophylactic penicillin up until the age of 6. After the age of 6, they can stop unless they've had a history of pneumococcal sepsis or unless they've had their spleen taken out. If they've had their spleen taken out or if they have a history of sepsis, we keep these children on prophylactic penicillin for a lifetime. Okay. And yet again, we want to make sure that they are getting their Pneumovax shots. this is a shot that they will be getting and that your children without sickle cell disease or without immunocompromised issues, they won't be getting, but you need them for your sickle cell patient. So a treatment and infection, honestly, they're more than likely going to be hospitalized. We want to seek care anytime, and this is education. This is great education. Anytime a patient with sickle cell disease has a fever of 101 or greater, they need to be evaluated. We want to do blood cultures to look for that infection, and we want to go ahead and treat them, prophylactically treat them with hardcore antibiotics, whether that's or IV antibiotics. But we want to monitor for the infection, and we want to prophylactically treat the infection until we can prove that there's no infection. Okay. Question: what medication should you make sure a child with sickle cell disease is taking every day, twice a day? What is that? That is B, penicillin. So we have to make sure our child is taking prophylactic penicillin. So, anemia is another complication of sickle cell disease, and this is due to the rapid destruction and a shorter lifespan of the red blood cells. Remember, a sickle cell only lasts 10 to 20 days. So, after 10 to 20 days, those cells basically pop, those sickle cell disease pop, and they let off bilirubin as they pop. And that bilirubin is why you get the um, jaundice appearance of the eyes. Scleroicterus is what we call that. So they'll have the yellowing of the eyes, maybe even the yellowing of the skin sometimes. But other clinical manifestations are paler. Like I said, the jaundice. They're going to have the low H&H, dark urine, and a very high retic count because as those red sickled blood cells pop, it's letting the body know, hey, we need more, we need more. So let out those immature ones, and so you'll have the high retic count. Treatment for anemia, um, if it's a very severe anemia, if their counts are really below their baseline counts, we're going to give them a blood transfusion. We don't treat with iron because this is not iron deficiency anemia. This is anemia because those of red blood cell destruction. Um, And there is something called aplastic anemia that we're not going to discuss, but it's basically where everything is wiped out. The red blood cells, the white blood cells, everything is wiped out, and they have a low retic count because their body can't make more red blood cells. But that's a parvo B19. You'll hear about that. Parvo B19 causes an aplastic crisis in patients with sickle cell disease. It also causes, that parvo B19 in any immunocompromised patient. That's a big scary thing because it can wipe everything out of them. Stroke is another major complication of sickle cell disease. Blood flow, it goes to the brain, so you can have those sickle cells clogging those vessels to the brain. So it occurs in 8% of hemoglobin SS patients. You can have an infarct, basically occlusion of those vessels, or you can have a hemorrhagic stroke. In these patients because those sickle cells can kind of weaken those vessels. And when you have a weak vessels, you have a risk of hemorrhagic stroke. The most common presenting signs is a weakness or paralysis on one side, but there's other things, slurred speech, like I said, weakness, severe headache, like, oh, my head is hurting. They're crying, they can't do anything. This is the worst headache of their lives. You need to get them to medical evaluation in the emergency room quickly. So if a patient or a family calls you and says, she's just crying over her head, it's hurting her so bad, put down the phone, get them to the emergency room right away. But we do monitor patients for this. We do a yearly ultrasound of their brain to assess the blood flow to the brain to make sure it's a strong, steady blood flow to the brain. And it's called a TCD, a transcranial Doppler. So we will do that yearly for our patients who have hemoglobin SS disease or true sickle cell disease, just to make sure that their blood flow is great and try to prevent those strokes from happening. Treatment. Like I said, if they ever have any of those presenting symptoms, we want to get them to the hospital immediately. They're going to do an exchange transfusion. An exchange transfusion is basically we take away their blood because their blood has the bad sickle cell blood sickle cells in there, and we give them good blood, healthy blood without the sickle cells. So we want to replace their blood. So that's called an exchange transfusion. And so then we'll get them stable in the hospital. And then after the hospital, more than likely, this patient who's had a stroke, who suffered a stroke, is going to be doing monthly blood transfusions. Um, and they'll do that for the rest of their lives to prevent, they'll do that to prevent another stroke from happening because reoccurrence or subsequent strokes is very common because we already tell that their blood vessels to the brain are weak and have issues. So we give them blood every month, and the blood that we give them is healthy blood without sickle cell disease, without sickle cells. The less sickle cells you have, the better chances of you not having another stroke, of those sickle cells not occluding your brain vessels and you having another stroke. We can also put them on hydroxyurea too. We'll discuss a little more about that. But yes, treatment is monthly blood transfusions and or hydroxyurea. Anytime you give a patient blood transfusions, several blood transfusions, blood transfusion every month, we're giving them iron because there's iron in healthy blood. And so they're going to have to do some sort of chelation therapy. Chelation therapy means we're removing the iron from the body, which is crazy, right? Because iron deficiency anemia, they need iron. But in sickle cell disease, too much iron is very, very toxic to organs. So we have to remove the iron from the blood. Acute chest syndrome or pneumonia. So this you're going to see on the X-ray, on the chest X-ray, infiltrates. Common sign and symptoms, you're going to have the fever, the cough, difficulty breathing, chest pain, back pain. But this is any patient with sickle cell disease with respiratory symptoms, with the fever and like bad respiratory symptoms. You want to get them in, do a chest X-ray, and we want to look for this infiltrates on the X-ray. And more than likely, this patient has some form of pneumonia or chest syndrome, which is already bad. It's bad enough for the lungs, but then you have the fact that you have sickle cell disease, and those sickle cells are decreasing oxygenation to your lungs. So this is bad. So um, get them to the emergency room immediately. You want to put them on some oxygen. You want to give them some IV antibiotics to get rid of whatever's causing this. Um, and more than likely, they're going to get a blood transfusion. Anytime a sickle cell patient is really, really bad, we're going to do a blood transfusion because what's causing their issues is their blood, those sickled cells in their blood. So we need to get them some good, healthy blood to treat the issues that they're having. Splenic, splenic sequestration. Um, like I said, we discussed how the spleen acts as a filter. Well, those sickle cells get clogged up in that spleen and they cause the spleen to swell. Okay, so this is a medical emergency because if the spleen gets clogged up, that means all the blood is going into the spleen, but nothing's coming out. So then you're going to have really big spleen and then signs of severe anemia, right? Because there's no blood in the body. So treatment for this is a blood transfusion and surgery to remove the spleen. Like I said, if once you remove the spleen, we're going to extend your prophylactic penicillin. So you'll be on prophylactic penicillin for a lifetime. Gallstones is another complication um, of sickle cell disease, and this is a patient who's presenting with abdominal pain, and it's always associated after eating. They just have severe abdominal pain. Um, Gallstones need to be in the differential, probably next to other things, sickle cell crises and constipation. But you're going to do an abdominal ultrasound, and the treatment for that is surgery. They just take the gallbladder out. So the reason why children with sickle cell disease have problems with their gallbladder and need to be removed is as those sickled red blood cells pop, they let off bilirubin. Well, bilirubin is excreted through the body, through the gallbladder. And for some reason, all of that bilirubin causes crystallizes and causes gallstones. So more than likely, this pain is caused from those gallstones. And so they just remove it. They remove the gallbladder. Priapism. So this only affects males, and it's a prolonged, sustained, painful erection. So this is a sickle cell crisis in the penis. Those sickle cells clog up those little veins, those small vessels that's going to the penis, and it is a painful erection. So we have to educate our young boys about this, and it's embarrassing for them to talk about, but we have to say, there's a difference between an erection because especially our adolescent boys, because they get erections, um, but an erection should not be painful. We have to let them know that if you're having an erection that's painful, then we need to do some things about it. So you want to increase fluids, you want to treat it. But however, if it's approaching that hour, 2 hour mark and nothing has happened, you want to get them to the emergency room quickly, because we need to take care of this because we don't want to cause loss of function of this organ. So we have to educate our boys about this. Blood transfusion, like I said, anytime we're treating a patient with a complication of sickle cell disease, we're probably going to do a blood transfusion just to basically clear their body of all those sickle cells and give them good, healthy blood without sickle cell disease. So we use it for stroke prevention, primary and secondary stroke prevention. Um, time a child with sickle cell disease needs to be sedated for anything, any sort of procedure, any sort of surgery in the OR, we give them a blood transfusion. We want to make sure that their blood counts are high enough to sustain deep sedation. Okay, so we'll use blood transfusions preoperatively, and then sometimes we use blood transfusions in sickle cell patients for healing after surgeries. So anytime you're going to have a patient who may have had like an orthopedic surgery, and it's going to take good blood flow to really help heal an area, a bone or incision site, or they had a major surgery, and it takes good blood flow and good oxygenation to heal that site. We're actually going to have to give this sickle cell patient monthly transfusions. It is not for a lifetime. Normally, it's for about 6 months or so, 3 to 6 months. But we want to promote healing because what a patient with sickle cell disease lacks sometimes is that good, healthy blood flow, good oxygenation all around the body. And then anytime that you're giving a child lots of blood transfusions, and we want to keep up with them, how many they've had, we want to look at iron levels and make sure we do not need chelation therapy. If iron levels are high, we will want to put the patient on some type of chelator, um, Desferal, Xjade, or Jnude, you'll hear. These are all oral, once a day chelators that the patient takes by mouth. They mix it in water or juice, they drink it, and it actually helps them excrete the iron out of their body through their feces. So they poop out all that iron. Other considerations, um, growth and development, we want to look at them on the curve, on the growth curve. Children with sickle cell disease, they don't have that good healthy blood flow that you need for growth and development. So a lot of times they're smaller than children their own age. So and sometimes that can be, an issue for them. So let them know that they will grow, they will get bigger, but it's going to happen slowly. It's going to happen later than their peers. They're going to go through puberty maybe a little bit later than their peers. Health supervision, we want them to get all of the immunizations that everyone else gets, with the exception of those two additional immunizations, the Pneumovax vaccine. We want them to eat balanced nutrition. We want them to stay hydrated. We are always pushing fluids on our sickle cell patients because guess what? That dehydration causes sickling of those cells, which causes pain episodes, which causes complications. So always increasing fluids. We want them to exercise. We want them to participate in sports. We do discourage against football and and in sports that are really hard contact sports because of the spleen, because of the spleen, because they have issue of splenic sequestration because of those sickle cells getting clogged up in the spleen. So their spleens are a bit bigger, and we don't want to risk rupturing the spleen. So we do advise against football, but baseball, basketball, if you're able to get breaks and stay hydrated, we're fine with that. Of course, other things like swimming and things like that. So we do want them to participate in sports. And then we're always educating them about what type of sickle cell disease they have and what complications they're at risk for, and they need to watch signs and symptoms they need to watch out for. Hydroxyurea. So like I said, this is a cytotoxic drug, and it was used as chemotherapy for our patients with oncologic issues. However, we were giving it to them and realizing that, hey, what this is doing is increasing the production of that hemoglobin F. And guess what hemoglobin F does? It protects our sickle cell patients from complications. So, this is a medication that we give our sickle cell patients to help increase the hemoglobin F levels, which protects them from their sickle cell complications. The thing about this is it can drop platelets and white blood cells, so it requires regular monitoring of the labs. It must be taken every day. This is not like I have a headache, I need to take a medication. It doesn't treat complications. What it does is it prevents complications. So it has to be taken every single day. Compliance is always an issue. Having a child remember to take a medication every single day, but they take it every single day. They'll take it for a lifetime as long as it's working, as long as it's not dropping their counts dramatically. But as the family nurse practitioner, as the FNP taking care of a patient with sickle cell disease on hydroxyurea, you may be responsible for helping monitor labs. So the hematologist may, require you to take monthly labs or take labs every 3 months or so just to check the counts and make sure they're okay. And anything off on the labs, you might have to report them back to the hematologist and say, hey, she's on this dose, but I see that the white blood cells are dropping a little bit. And so you would hold the medication for a little bit and then start it back, maybe even start it back at a lower dose. However, you will have guidance with hematologists in this area. So hydroxyurea, just know that if you've got a patient with sickle cell disease, they may be prescribed this medication. So the cure for sickle cell disease, there is a cure. It's a bone marrow transplant. So you got to have a match. They want a match for a full sibling, a HLA match for a full sibling from cord blood. Occasionally you can get it from a half sibling, but it's rare. Or you can get it from a donor, but it's rare. But it has to be a full match. And what it is the patient with sickle cell disease will take chemotherapy to completely remove their own bone marrow cells. Because the marrow makes the red blood cells. So if a patient with sickle cell disease, their marrow makes sickle cells. Well, if we can remove all of their marrow, completely knock it out with chemo, and then from the donors, inject the donor's marrow into the body, then the donor's marrow, who doesn't have sickle cell, they make normal, healthy red blood cells. So this is a bone marrow transplant. This is the cure. It's 85% success rate in patients who have full matches. So 85 is a really good number. It's high, and especially if a patient is having a lot of complications. If they've had stroke after stroke, then there's so many deficits. 85 is a really good. It's a really good success rate. But because it is 85 and not, 99.9 or, 95 even, then a lot of patients are hesitant to do it because there's a high incident of graft versus host. Sometimes in patients with unrelated donors. Um, but like I said, we recommend it, we educate our parents on it. Some are taking it seriously, especially the ones who have full matches. They're taking it seriously. Um, and it is a cure. You no longer have sickle cell disease. If you go through this and it's successful, you are healthy, happy, and normal, and you don't have sickle cell disease anymore. Now you may have issues related to organ damage from previous sickle cell issues, but your body no longer makes sickle cell disease. So we're educating our parents and families, and we're pushing for this because it is a cure.